essentially just talk about knees and stuff like that.
Okay.
I'm going to get rid of the patella just so you don't really need to see it. You okay?
Mm-hmm.
So basically in the knee, as you already know, you know about the ACL and PCL. And here's our ACL.
Mm-hmm.
And if you tore it, you said skiing?
Mm-hmm.
Skiing 20 years ago, you know, you had a little bit of laxity on the ligament, meaning like, because it's not really there, which, you know, not a really big shocker. But it didn't like translate, like really slip out. So
Mm-hmm.
I don't
That's
really
good.
need to have that much of a conversation about it. I don't know how much you want to go skiing in the future, but
I've been skiing.
Beautiful.
I've been skiing every year.
Great.
For the last 20 years.
Great. But yeah, so I'm not gonna even say anything about it because like it wasn't significant for me to be like raise my eyebrows and be like,
Mhm.
oh my gosh, you need to do this. So we'll leave
Okay.
we'll leave that at bay. So when you subject your knee to this type of position and you're really pulling on it,
Mhm.
that's called a valgus force on the knee.
Okay.
Right? So there's a varus force and there's a valgus force. And the valgus force is where we kind of apply this type of force going that direction, and it kind of gaps the knee on both ends, right?
Okay.
Essentially lengthening those ligaments. Oftentimes you'll feel a pop or a click. Sometimes it could be joint related. Sometimes it can be the LCL, which look at where the LCL attaches to.
Mhm.
Shocker, it attaches to that bone that you said it's super tender.
Mhm.
This is called the fibula, and this is the fibular head
Mhm.
right there.
Yeah.
So it's super important. Also, people don't realize that the fibular head has connections, like little fibers that kind of
Ah.
attach it on there. And this is one of the reasons also why me kind of like shoving it forward,
Okay.
which is what I was doing, going this direction. I said, is it worse this way or this way? You said, this way. It tends to be a little tender.
Uh-huh.
So the LCL is intact, just so you know. So there's no slippage of it. It's a stable
What
knee.
popped?
I think you kind of popped or strained, or sorry, technical term is sprained when we were talking about
Yeah.
a ligament. You sprain the LCL, but also that LCL, where does it attach to? And we start realizing these fascial attachments, and these attachments have attachment not just to, you know, the femur, but also to the head of the fibula. So I think you had a little bit of the LCL disruption more at the fibular head,
Right.
which is
Okay.
super common.
Okay.
You know, and then that's one of the reasons. So myself included, that guy Nick, we all had similar MOIs. We call mechanisms of injury, and mechanism is a valgus force. I actually hurt my knee in this position. He did the same exact thing. So I think you were first, I was second, he is third, and doing stuff like that can sometimes feel that strain.
Yeah.
A lot of times there's referral patterns and referral pains either posteriorly, and knee pain is very different for every person. Either posteriorly, kind of like back here, there's usually pressure, but oftentimes at the first like week or two, it's usually down the fibular, the peroneals, longus, and brevis. So it's really important to strengthen the knee behind the knee. If we add some of the musculature and stuff like that behind that, one of the key foundational exercises that we would like to eventually incorporate to help knee stability, not that you have an unstable knee, but just things that to think about in the future, would be some exercises that we'll show you, but really just strengthening the hamstrings. A lot of people just like to lengthen. I'm not against lengthening. And that's why I asked about your program. I said, what do you do? What don't you do?
Yeah, no, I think that's, well, I used to do reformer Pilates for a number of years, and my instructor was like, it's all about your hamstring strength. And we would do all those stability ball type exercises, right, where you're on your back and you hike your feet up and then roll the ball in and out. We do a lot of those. And then
those
when
are
you're
hard.
on the reformer, the bar, we would do, double feet and single feet and trying to move yourself.
So that's all good then.
Yeah.
Because that will, look at where the biceps femoris, by the way, this is the strongest part of the hamstring. Look at where it attaches to. Now
So I did that I have a ball, and I tried to do that exercise a couple weeks ago, and when I was coming in, this was quite painful.
Yeah.
When I tried to bring the ball in.
Yes.
With hips out.
But that's where like the application of the time, just like if you go back to your quote microbiology days,
Yeah.
you would know that like it's really about the sequence of timing to get to express that protein or whatever,
Yeah.
right? It's like the timing of it. So if I give you an exercise that's too hard too early, you cause a little bit more irritation in that area versus actually a healing kind of environment.
Right.
And so if we take this type of disruption and we just either fade it, and I'm going to fade it as well, look at where like the LCL is right behind it. It's literally kind of like they're attached together. It's not like this is a separate muscle, this is a separate muscle, this is separate, this is separate. They're bound together by fascia, and they also typically kind of have like posterior attachments too, and that's one of the reasons why sliding that fibular head side to side sometimes you get disruption. But basically what I'm saying is your knee is stable. I did a lateral test like to try to see if it would do that, and it did not do that. Your knee is stable. So congrats on that. This is a simple sprain strain of the LCL, maybe a little irritation of the biceps femoris, which is very, very common. And so I'm going to show you some things that you can do. You're about 6 weeks out, so you're much further ahead than I am. You're much further ahead than other people in this office that I just said. But I think we just need to give you a couple of exercises that will help you in that sense. And I'll do some work on that too. When it comes to, let's zoom out, your lower back. Now, a lot of people, and I'm going to show you on this model, a lot of people think it's, and if you know much about sciatica, it's pretty much a disc herniation that puts pressure onto the nerve, and then those nerves go down to the spine, irritate the sciatic nerve. So true sciatica typically is very, very severe. It's pretty intense. You have a very mild version of it as well.
Okay.
So congratulations on that.
But I'm still in pain.
Yes, but what happens is typically as we bend forward and we kind of do this, we wedge the spine going posteriorly, or in this case backwards, right? And it'll nick the nerve as we go forward. So as we go forward, this kind of can translate forward and kind of hit that nerve. And when I was doing some stuff on your belly and I was pushing and doing this, you're like, actually that's starting to feel better. Most of the time what that does is that provides extension and then actually draws that disc back forward. Now, you didn't present with anything that is severe, no bearing down, no coughing, no sneezing, me raising your legs, me having you do sit-ups. These are indications of extreme compression if somebody can't go and like bear down. So whatever you've done over the last 20 years to stay fit and healthy has probably saved you quite a bit. But one thing I noticed is that like when we do the hamstring stretch, which is when I said I'm going to lift this leg first for comparison, and then we'll do this one, and you're like, I'm starting to feel it. That's the same thing as bending down, touching your toes. It's a hamstring stretch. What we did is, we call this a neurodynamic test. We literally pulled down on the nerve, and then as you see where it splits, remember when I kind of like did these weird things with your foot? What I'm literally doing is testing each division of that sciatic nerve, the peroneal division, the tibial division, the sural division. I can have that conversation because it didn't affect you. So really what I'm saying is this, the upper portion division, the straight hamstring, and then I even back down a little bit, and then I kind of flexed your foot a little bit, which that draws a lot of the fascia and the tension down inferiorly, and that didn't cause it. So true sciatica will really start popping up around 25 to 40 degrees. You were much higher, around about 65 degrees, so it's a lot more mild version. And that bending down, touching your toes, why is that so painful for the above average person? Is because we're taking the spinal cord and we're pulling upwards, so north, while we take this south and we're pulling.
But I mean, do you think this is connected to this though? Because this started after this happened.
Interesting question.
Yeah.
So it can. It's interesting that it's along the same distribution neurologically. Yeah. So it can have done that, or is it a coincidence? I don't know. We could treat both. If you want to go down to the scientific component, we can always say it's kind of connected, because the hamstring is part of the L5S1 distribution, which is, if we add the hamstring over that nerve, that is the same sciatic nerve path. But
so when I pop, what's popping?
When you pop this?
Yeah. When I bent over and this something back.
Oh, your hips. That was like your hip.
Oh.
So.
But I feel like sometimes I feel like something's popping back here.
It probably feels like a lot of pressure from just the hamstring being
Mm-hmm.
overload. But again, you got to remember that your hamstring is kind of like that. You have a hamstring tendon and type of, I guess you could say, ligamentous. So a very connective, like dense connective tissue issue there,
Mm-hmm.
and more of like a neuro issue there.
Oh, okay.
One can say that they can be interrelated, and
Mm-hmm.
I can kind of go down the geeky scientific nerve rabbit hole on that one, or we could just treat them as two
Let's
different
just treat
things. I think we should just treat them as two different things, but yet that are integrated together. And like that's just how I treat people anyway. It's like, hey, like if this is messed up, let's fix this. If this is messed up, let's fix that. Oh, this looks good. Okay, we're gonna pass on that today.
Okay.
A lot of times, just to give you a little like background, I guess you could say, is a lot of people's hips flexors get really shortened from one sitting.
Yeah, that's me.
Two,
I have that too.
when the hamstring is either pissed off, the pelvic imbalance is there, or you're having sciatica, what those hip flexors do, the psoas really, and the iliopsoas and the iliacus, those muscles bear down onto the hip flexors to protect it, but they also go and directly attach to the lumbar spine.
Mm-hmm.
So they are doing their job, but they also need to be released and strengthened at the same time. So the thing I think we need to do is find out what's the correct order of operations.
Yeah.
And I think that now that I know what your rehab program is, now that I know what your strength training program is, like, and where can we fill in some of the holes in the buckets, and just say what's going to actually make you feel better.
Okay.
So I think that's what we'll do. We'll start with the lower back and work our way down. I think that will help you.
Okay.
Any questions for me?
No.
All right. Let's get you started then.
Let's do it.
All right. Yeah, let's get you fixed up so you can